Good afternoon, everyone. Thank you for joining. Thank you for joining us at the California Dialogue on Cancer Surveillance Data Webinar Series. My name is Sheila Senyo, she/her, Strategic Alignment Specialist for the Cont Cancer Program and the California Cancer Registry. Please feel free to introduce yourselves in the chat with your name, pronouns, organizations, and where you are joining from today. Next slide. I'll go over some housekeeping while everyone is typing in your intros. All participants have been muted, but we will leave the chat open for questions. We'll also have an allotted Q&A after the speaker's presentation. And please stay until the end of the presentation to participate in a short webinar evaluation. Again, for those who are just joining in, please type in the chat your name, pronouns, organization, and where you're joining from. The California's Comprehensive Cancer Control Program is a CDC-funded program that provides leadership and coordination of statewide comprehensive cancer control efforts. The Comp Cancer Program leads the Cancer Control Coalition, which is CDOC, and is also required to develop and implement a state cancer plan. Currently, we are still implementing strategies from our current 2021-2025 state plan. And just to note, we are in the process of revising the next iteration of a 10-year plan. Next slide. As a background information, these are the current cancer plan topic areas. CDOC work closely with the Cancer Registry and other partners to implement strategies from the surveillance topic areas. The Comp Cancer Program collaborates with the UC Davis CalCARES program on our various surveillance goals. CalCARES is an acronym for the California Cancer Reporting and Epidemiologic Surveillance Program. They have supported key strategies such as ensuring wider dissemination of cancer data by producing culturally and linguistically appropriate cancer reports. In today's surveillance data webinar, a couple of our associates from UCD will present one of their published reports. This report informs cancer control and prevention partners about the continuing impact of COVID-19 on cancer incidence, early detection, and survival in California. Disruptions in healthcare during the pandemic has had a lasting impact on early cancer detection, leading to delayed diagnosis and worse outcomes, highlighting the need for targeted mitigation strategies. To explore this important issue, we welcome Rita and Julianne, who will share their expertise and provide insights on overcoming these challenges and improving early detection. Rita Villazana is a data disclosure coordinator with the CalCARES program within the UC Davis Health Comprehensive Cancer Center's Office of Population Health. She coordinates requests of CCR data, provides support to researchers, and helps them navigate the data disclosure process, develops cancer surveillance reports and data visualization materials for the central registry, and is a member of NACER's Research and Data Use Social Media Work Group. She holds a Master of Public Health degree from University of Texas Health Science Center in Houston. Julianne Cooley is a statistician within the CalCARES program within the UC Davis Health Comprehensive Cancer Center. She leads the production and evaluation of statewide analytic cancer data files for cancer surveillance and research, investigates and identifies solutions for data quality concerns from data users, develops and conducts epidemiologic studies utilizing California Cancer Registry data and large linked analytic files, and develops surveillance reports that describe the burden of cancer in California. Please welcome Rita and Julianne.
Okay, thank you, Sheila, for the introductions. Our presentation today will be on a report titled The Impact of COVID-19 on Cancer Incidence Early Detection in California in 2021. For the presentation, I will be turning off my camera and turning it back on for questions. Okay, can we go back to the previous slide? Yeah. So the focus of this presentation is to share findings on a report my colleagues and I prepared on the impact of COVID-19 on cancer incidence, early detection, and survival in 2021. This report is a continuation of a previous report that focused on the impact of COVID-19 on cancer incidence, early detection, and mortality in 2020. The cover for these reports is on this slide, and both of these reports can be found on the UC Davis Comprehensive Cancer website. Next slide, please. Okay, to get started, I would like to share some background on why we developed our report. Research shows that cancer screening saves lives through the early detection of cervical, colorectal, breast, lung, and melanoma cancers. And those who are diagnosed with cancer at later stages have fewer treatment options and poorer survival. Previous studies showed that limited access to in-person healthcare and cancer screening during the pandemic led to widespread delay in cancer detection. Findings from our initial report showed that out of the 21 most common cancers, 17 cancers had lower than expected incidence, suggesting misdiagnosis in 2020. The report also highlighted disparities in early detection and stage of diagnosis among those living in the lowest SES neighborhoods. Historically marginalized communities and individuals older than the recommended screening ages for the screening detectable cancers. In 2021, due to the emergence of highly transmissible COVID-19 variants, the pandemic continued to disrupt healthcare delivery and pose significant challenges to already strained health systems. And as a result, cancer screening uptake failed to return to pre-pandemic levels. Next slide, please. So for our report, we had two aims. The first aim was to continue to evaluate the impact of COVID-19 on cancer incidence and survival. And the second aim was to examine disparities in the early detection of screening detectable cancers, which included breast, cervical, colorectal, lung, and melanoma. Next slide, please. Okay, now I'll go over methods. To evaluate the impact of COVID-19 on new cancer diagnosis, we calculated observed to expected incidence ratios for 21 of the most common cancers. The American Cancer Society annually estimates the number of expected new invasive cancers and deaths by state for 21 of the most common cancers. To calculate the observed to expected ratios, we used ACS values as the expected values and used California Cancer Registry data for invasive tumors diagnosed in 2021 as the observed values. Then we multiplied the quotient by 100 to create a percent. 95% confidence intervals were also calculated for each site. Please, next slide, please. Okay, to examine disparities in screening detectable cancers, our analysis included both in situ and invasive breast, cervical, colorectal, lung, and melanoma tumors diagnosed among California residents from 2006 to 2021. We calculated age-adjusted incidence rates using SEERSTAT software and calculated trends from 2006 to 2001 using joint point for each cancer site. The calculation of trends excluded 2020 because it was an outlier due to the missed detection of many cancers. However, the 2020 incidence rate will be shown in figures. For our trend analysis, we looked at trends by age, race, ethnicity, stage of diagnosis, and sex. Although we calculated trends from 2006 to 2021, the focus of this report was to look at differences in the incidence rate in 2021 versus 2020 and pre-pandemic in 2019. Next slide, please. Okay, so for the survival analysis, which Julianne will cover later in the presentation, we use flexible parametric models to estimate the one-year relative hazard of death for patients diagnosed with screening detectable cancers during the pandemic in 2020 versus pre-pandemic in 2018. This report has limitations. Population denominators were not available for exact screening recommended ages for all screening detectable cancers. So trends were calculated using the closest possible age ranges available in SEERSTAT. For example, the screening recommended age for colorectal cancer is 45 to 75 years. However, our trend analysis used 45 to 74 years. Next slide, please. Okay, as mentioned in previous slides, to evaluate the impact of COVID-19 on new cancer diagnosis in California in 2021, observed to expected incidence ratios and associated 95% confidence intervals were calculated for 21 common cancers. For 15 cancers, the OE ratios were significantly less than 100%, indicating that fewer than expected cancers for these types were diagnosed in California. The lowest OE ratios were among cancers of the cervix, liver, myeloma, all of which had approximately 15% fewer cancers diagnosed than expected. The OE ratio for stomach cancer was significantly higher than 100%, indicating that more of these cancers were diagnosed than expected in 2021. 4 out of the 5 screening detectable cancers had fewer diagnoses than expected in 2021, including breast, cervical, lung, and melanoma. In the next slides, I will go over findings for each of these screening detectable cancers. Next slide, please. Okay, so for female breast cancer, our results showed that in 2021, over 36,000 breast cancers were diagnosed in California. The most common age of diagnosis was among those 40 to 74 years of age. The majority of these cases were diagnosed among non-Hispanic Latinas, and most women diagnosed lived in the highest SES neighborhoods. Additionally, there were 2.1 fewer invasive breast cancer diagnoses than expected in California in 2021. Next slide, please. Okay, so this figure here shows the age-adjusted trend analysis by age group. And in 2021, the incidence rate among the 2 oldest age groups was higher than 2020 and 2019. And among those 0 to 39, the incidence rate in 2021 returned to the same rate as 2019 after a decrease in 2020. Next slide, please. This figure here shows our trend analysis by race and ethnicity. In 2021, the incidence among American Indians, Asian Pacific Islanders, and non-Hispanic white Latinas was higher than in 2020 and in 2019. In contrast, the incidence among Black African Americans and Hispanic Latinas in 2021 was higher than 2020, but lower than pre-pandemic in 2019. Next slide, please. Okay, this slide shows our trend analysis by stage of diagnosis. Breast cancer incidence rates increased in 2021 compared to 2020 and 2019 for both in situ, localized, and regional remote stages. Next slide, please. Okay, so our chapter on cervical cancer. The results showed that over 1,400 cases of cervical cancers were diagnosed in 2021. The most common age of diagnosis was among those 20 to 64 years old. The majority of cases were diagnosed among Hispanic Latinas. The majority of these cases were diagnosed at the regional remote stage, and most women diagnosed lived in the lowest SES neighborhoods. Additionally, there were 16.4 fewer invasive cervical cancer diagnoses than expected in 2021. Next slide, please. Okay, and this slide here shows our trend analysis by age group. Among those aged 20 to 64, the incidence rate in 2021 was higher than in 2020, but it was lower than the 2019 rate. And among those older than 65, the 2021 incidence rate was lower than 2020 and 2019. Okay, this slide shows our trend analysis by race ethnicity. The incidence of cervical cancer among Black African Americans, Hispanic Latinas, and American Indians in 2021 was higher than 2020, but it was lower than the 2019 rate. For non-Hispanic Latinas, non-Hispanic Latina whites, the incidence in 2021 was lower than 2020 and 2019. And among Asian Pacific Islanders, the incidence in 2021 was higher than 2020 and back to the similar rate of the 2019 rate. Next slide, please. This slide here shows our trend analysis by stage of diagnosis for cervical cancer. The incidence rate of cervical cancers diagnosed in situ and localized increased in 2021 compared to 2020, but it was the same as in 2019. And the incidence rate of cervical cancers diagnosed regional remote increased in 2021 compared to 2020, but it was lower than 2019. Okay, so colorectal cancer. Our results showed that over 15,000 colorectal cancers were diagnosed in California in 2021. The most common age of diagnosis was among those 45 to 74 years of age. Most cases were diagnosed among non-Hispanic Latino whites. The majority of cases were diagnosed regional remote stage, and most cases were diagnosed among individuals living in middle SES neighborhoods. More than half of these cases were diagnosed among men, and there are 1.3 more invasive colorectal cancers diagnosed than expected in 2021. Next slide. Okay. This slide shows a trend analysis for colorectal cancer by age group. The incidence rate for all age groups in 2021 was higher than 2020, but it was lower than 2019. Next slide. This slide shows our trend analysis for colorectal cancer by race and ethnicity. In 2021, the incidence for all races and ethnicities was higher than 2020, but it was lower than the 2019 rate. Okay, and this slide shows our trend analysis by sex. Both men and women experienced higher incidence for colorectal cancer in 2021 compared to 2020. However, the incidence in 2019 for both sexes was higher than in 2019, higher than in 2021. Okay, this slide shows your trend analysis for colorectal cancer by stage diagnosis. The 2021 incidence of cancers diagnosed in situ and localized and regional and remote was higher than in 2020, but it was lower than the 2019 rate. Next. Okay, lung cancer. So our results showed that close to 16,000 lung cancers were diagnosed in 2021 in California. The most common age of diagnosis was 50 to 79 years. Most cases were diagnosed among non-Hispanic Latino whites. The majority of these cases were diagnosed regional remote stage, and most cases, more cases were diagnosed among individuals living in middle SES neighborhoods. More cases were also diagnosed among men than women, and there were 11.5% fewer invasive lung cancers diagnosed than expected. Okay, this slide shows your trend analysis by age group. For those 0 to 49 years and those 80 and older, the incidence was greater in 2021 than in 2020, but it was lower than the 2019 rate. And for those 50 to 79 years, the incidence decreased from 2019 to 2021. Next slide. Okay, this slide shows your trend analysis for lung cancer by race and ethnicity. For all races except American Indians, the incidence in 2021 was higher than 2020, but it was lower than the 2019 rate. Among American Indians, the rate increased from 2019 to 2020, but then it decreased in 2021. This slide shows our lung cancer trends by sex. In 2021, the incidence among both sexes was higher than 2020, but lower than 2019. Next slide. And this slide here shows our trends by stage of diagnosis. In 2021, more in situ localized tumors were diagnosed than in 2020, but those were fewer than, but it was fewer than 2019. Among regional remote tumors, the 2021 incidence rate was the same as 2020, but it was lower than 2019. Okay, and so for our final chapter for the screening detectable cancers was on melanoma. And in 2021, close to 22,000 tumors were diagnosed in California. The most common age of diagnosis was among those 65 years and older. The majority of cases were diagnosed in situ localized and among non-Hispanic Latino whites. The majority of these cases were diagnosed among individuals living in the highest SES neighborhoods, and more of these cases were diagnosed among men than women. And there were 5.2 fewer invasive melanoma cases diagnosed than expected. Okay, this slide shows our trend analysis by age group. Individuals 0 to 14 years had the same incidence rate from 2019 to 2021, and those who were 15 to 39 years of age and 65 years and older had greater incidence rates of melanoma in 2021 than in 2020, but that 2021 rate was lower than the 2019 rate. And those who were 40 to 64 years had a higher incidence in 2021 than the previous 2 years. Okay, this slide shows trend analysis of melanoma by race and ethnicity. In 2021, the incidence of melanoma among non-Hispanic Latino whites, Black African Americans, Hispanic Latinos, and American Indians was greater than 2020 and 2019. The 2021 incidence among Asian Pacific Islanders was greater than in 2020, but lower than the 2019 incidence rate. This slide shows the trend analysis of melanoma by sex. In 2021, the incidence of melanoma among both sexes was greater than 2020 and 2019. And this slide shows the trend analysis by stage of diagnosis. In 2021, the incidence of tumors diagnosed in situ localized was higher than in 2020 and 2019. Incidence rates for those diagnosed regional or remote were the same in 2019 and 2021, after decreasing in 2020. So now I'll hand it over to Julianne, who will go over the survival analysis chapter of our report.
Thanks, Rita. So the differential risk of death for cancer patients due to the COVID-19 pandemic was unclear, but prior studies have shown increased mortality of cancer patients infected by COVID-19 compared to the general population because they're immunocompromised. And additionally, limited access to in-person healthcare, cancer screening, follow-up of abnormal screening results during the pandemic led to a widespread delay in cancer detection and later stage of diagnosis, which, as Rita mentioned, those who are diagnosed with cancer after it metastasizes have fewer treatment options and poorer survival on average. Therefore, we leveraged the population-based California Cancer Registry to quantify the overall one-year hazard of death of patients who were diagnosed during the COVID-19 pandemic in 2020 versus those who were diagnosed in 2018, pre-pandemic. Sorry, the previous slide still, thanks. So we identified over 87,000 patients diagnosed with screening detectable cancers in 2018, including female breast, cervical, colorectal, lung, and melanoma. We'll refer to this as the pre-pandemic era. And then nearly 79,000 who were diagnosed during the pandemic era of 2020. And we did not include patients diagnosed in 2019 because the first year following their cancer diagnosis overlapped with the COVID-19 pandemic in many cases. Next slide, please. We used one-year hazard ratios to compare the rate of death over 1 year among cancer patients diagnosed during the pandemic relative to pre-pandemic. A hazard ratio of 1 indicates that patients diagnosed during the pandemic had the same risk of death within 1 year as patients who were diagnosed in 2018, while a hazard ratio or HR less than 1 indicates a lower risk of death for those diagnosed during the pandemic, and a hazard ratio greater than 1 indicates a higher risk of death for those who were diagnosed during the pandemic. Next slide, please. To evaluate the impact of the COVID-19 pandemic on the length of time patients survived following the diagnosis of their screening detectable cancer, we used flexible parametric models and 95% associated confidence intervals. And our models adjusted for the differential 1 year hazard of death due to sociodemographic characteristics such as age at diagnosis, health insurance type, race, ethnicity, marital status, stage at diagnosis, socioeconomic status, and number of comorbidities. Next slide, please. For 4 out of 5 cancer sites, hazard ratios were significantly higher than 1, indicating that the hazard of dying within 1 year was higher for patients diagnosed during the pandemic than pre-pandemic. Notably, among cervical cancer patients, the relative risk of dying within 1 year of diagnosis was 40% higher among those who were diagnosed during the pandemic compared to pre-pandemic. Among breast, colorectal, and melanoma cancer patients, the relative risk of dying within 1 year was 16%, 15%, and 13% higher for those diagnosed during the pandemic respectively. Some possible explanations include decreased early cancer detection, delayed or foregone cancer treatment during the pandemic, and overall increased mortality in the United States in 2020. The relative risk of dying within 1 year of diagnosis was stable among those who were diagnosed with lung cancer during the pandemic versus pre-pandemic. Next slide, please.
Okay, thank you, Julianne. To conclude this presentation, I will share and summarize our key findings. Incidence was lower than expected for 15 out of the 21 most common cancers in 21, suggesting missed early detection. Lower than expected incidence was observed for 4 out of the 5 screening detectable cancers, including breast, cervical, lung, and melanoma. Changes in the age-adjusted incidence rate of screening detectable cancers highlighted disparities by age, race, ethnicity, and stage of diagnosis. For example, the incidence of cervical, colorectal, and lung cancer among those older than the recommended screening ages was higher in 2021 than 2020, but it was lower than the 2019 rate. The incidence of breast, cervical, colorectal, and lung cancer among Black, African Americans, and Hispanic Latinos was higher in 2021 than 2020, but it was still lower than the 2019 rate. Similarly, the incidence of colorectal, lung, and melanoma cancer among Asian Pacific Islanders was higher in 2021 than 2020, but it's still lower than the 2019 rate. The incidence of colorectal and lung cancers diagnosed at in situ localized stage was higher in 2021 than 2020, but lower than 2019. And the incidence of rate of breast cancer diagnosed regional remote stage in 2021 was higher than the previous 2 years. As Julianne mentioned, the risk of death within 1 year of diagnosis was higher for patients diagnosed 2020 and than in 2018 for 4 out of the 5 screening detectables. And that percentage ranged from 13 to 40% higher, suggesting that patients diagnosed during the pandemic had worse survival outcomes. Next slide, please. Okay, given these findings, potential strategies to mitigate the lasting impact of the COVID-19 pandemic on early cancer detection include public health campaigns to increase public awareness and access to screening, working with policymakers to ensure funding is aimed at reducing barriers and increasing equitable access to cancer screening and ensuring that that is prioritized, educating primary care providers on disparities in early cancer detection and evidence-based interventions, and offering catch-up screenings for those who age out of the screening age recommendations during the pandemic. And finally, further research will be needed to evaluate the long-term effects of the COVID-19 pandemic on cancer outcomes. Next slide, please. And I would like to thank our co-authors, Julianne Cooley, Nellie Gottlieb, Brenda Hofer, Artie Patel, and Teresa Keegan, who helped put this report together. Thank you.
Thank you so much, Rita and Julianne, for your insightful presentation on the lasting impact of COVID-19 on early cancer detection and some screening strategies. I'd like to now open the floor for any questions and comments. Thank you, Joyce. Do we have any questions or comments? Go ahead, Dr.
Hi,
Anderson.
Stoney Anderson with the California Colorectal Cancer Coalition. It's not surprising. Our screening rate was the highest in 2018, according to the Behavioral Risk Factor survey, and it dropped in 2020, and it dropped even further in 2022. So it's not surprising that the 1 year mortality and that you found was increased by what, 13% or so. So that's not surprising. Our screening has fallen off. We're now probably 45th in the nation at our ability to screen for colorectal cancer, whereas in 2018 we were about 12th in the nation.
Thank you, Dr. Anderson.
Yeah, thank you for that comment, Dr. Anderson. why do we suspect that is? I mean, is it lack of? I mean, I feel like with the expansion of like the ACA, maybe there's more screening opportunities. Is it a lack of provider, or is it just people still avoiding the healthcare system?
That we actually don't know. We're working on it. We know that some of our large populations are screened at very low rates. Our federal qualified health center patients are low, and our Medi-Cal patients are low. One thing that ended in 2018, there was a big push by the American Cancer Society to get to 80% by 18, and we had gotten up to about 72%. We're now down in the low 60s or even lower. So there's a little less national effort.
Mm-hmm.
The California Colorectal Cancer Coalition and also through our breast and cervical cancer screening effort with Every Woman Counts, have continued to put out grants, but our screening rate has fallen quite a bit. Some of our screening obviously was the fit testing, and some clinics were using where you had to be actually at the clinic to get the fit test, but we need to work on making sure the fit test is mailed out where access to clinics is not necessary. So to answer your question quickly is we don't know why that happened exactly.
Thank you.
So this is Mark. Can you hear me?
Yes, Mark, go ahead.
Thanks. I really was fascinated by the presentation. Really appreciated it. And there's so much, and it went very fast. I realized you did a lot of work on that. But my question, because maybe it went a little fast. Maybe I just wasn't following so well on that. Could you elaborate a bit more on the mortality increase? Because I mean and how well, I guess. I think you touched on a bullet or two, but what we kind of do with that in the future. You know, you have we know you showed a pretty marked increase in mortality, um, and you know that's assumedly could have some relationship to the to later diagnosis, but typically, you know, mortality is a few years down the line. Could you just elaborate on that? What might be the causes and the kind of responses to that?
Yeah, thank you for your question. I think it wasn't, for one thing, it wasn't cancer specific survival. And so part of that could be the increased overall mortality in the United States from COVID. Also, it was 1 year survival, and for some of the cancers like cervical cancer, there were fairly low numbers. So there was a 40% increase in the 1 year overall survival, or the hazard ratio was 1.4. So patients were 40% more likely to die within 1 year of diagnosis. However, the numbers were still pretty low. So it was a smaller change in a small number can lead to a higher percent increase. Additionally, for patients who were diagnosed later stage, they could potentially have been diagnosed earlier stage if they had more access to in-person healthcare and screening and follow-up. But I think going forward, it's really important to continue to assess this, especially 3-year survival and 5-year survival, as the data come out, in order to really capture how these healthcare disruptions during the pandemic affected the survival of cancer patients who may have missed treatment in the first year following diagnosis or had delayed treatment.
Okay. Thank you very much, Julianne.
You're welcome.
I see a comment from Annie, and she's just saying that she has the same questions, given that models were adjusted for stage of diagnosis as well.
Okay, thank you. Yeah, I think that could have to do with the increased mortality during the COVID-19 pandemic of cancer patients relative to the general population as they're immunocompromised as well.
Thank you, Julianne. Let's see any other comments and questions. We can go right ahead with our evaluation webinar. So thank you once again, Rita and Julianne. And to wrap it up, please take a moment to complete a short webinar evaluation, which my colleague has shared in the chat. We'll have a couple more wonderful presenters and topics on the dates listed on your screen. Any recording and slide deck will be shared with you via email. You can view the past recordings also at that website, our coalition website. Again, thank you all so much for joining us today. Have a great rest of your week.
Thank you.
Thank you, everybody.